Hi, my name is Ilyas. Our group had case study one to focus on, and what I'll be focusing on is question one, which is the high priority clinical manifestations that led to the escalation of a MET call from Mr. Adrian Chani. Our group identified the respiratory rate, oxygen saturation, blood pressure, and oliguria as key indicators leading to a MET call escalation through the A to G primary survey format. I'll be covering these on the breathing, circulation, and fluids. So to begin with, we have breathing. Mr. Shani had a respiratory rate of 30 breaths per minute and an SpO2 of 86% on room air. What's more concerning is even when on 15 liters a minute of oxygen through a non-rebreather mask, his saturation only improved to 96%, meaning supplemental oxygen wasn't enough to correct the issue. He was also only able to speak in short sentences and had both wheezing and stridor on auscultation. What these signs tell us is he was in significant respiratory distress. The high respiratory rate shows his body was trying to compensate for hypoxia, meaning he's working harder to maintain oxygenation and clear carbon dioxide from his system, while the low oxygen saturation indicates impaired gas exchange, which can be due to airway edema and bronchospasm, likely from a severe allergic reaction. The stridor especially is a significant concern for upper airway compromise. On top of this, he also has a history of asthma and hay fever, which puts him at an even higher risk of rapid deterioration, and which is why this also required urgent MET activation and immediate care. Moving on to circulation, the case mentions Mr. Shani's blood pressure, which was 87/48, and his heart rate, which was 132 beats per minute. He also had a delayed capillary refill of over 4 seconds, weak peripheral pulses, and cold, clammy skin. These findings clearly indicate he was in circulatory shock. In his case, it's most likely distributive shock due to anaphylaxis, where there's widespread vasodilation and capillary leakage, reducing effective blood volume. The hypertension and tachycardia are classic signs that his body is trying to maintain perfusion but failing. This hemodynamic instability is another reason for a MET call on its own and highlights the need for immediate high priority action. Finally, we have fluids. So for fluids, we see is oliguric, meaning he has very low urine output, despite having IV fluids running at 80 mils an hour and being unable to tolerate anything orally. Oliguria is a significant indicator of inadequate renal perfusion. In this case, it's most likely due to distributive shock, which is common in anaphylaxis. In the script, distributive shock, vasodilation, and increased capillary permeability causes fluid to leak from the vascular space into the interstitial tissues, leading to reduced circulating blood volume. This tells us that his organs, more specifically his kidneys, weren't getting enough blood flow, which can quickly lead to acute kidney injury if not addressed. The oliguria also confirms that multiple organ systems were being compromised, further outlining the need for urgent intervention. Thank you.
Hi, my name is Pratima. The patient, Mr. Adrian Shani, presents with a respiratory rate of 30 beats per minute and an oxygen saturation level of 86% when breathing room A. The clinical sign results for a complex pathophysiological cascade that began with anaphylaxis caused by multiple yellow jacket sting and progressed through his pre-existing bronchial asthma and type 2 diabetes mellitus. Anaphylaxis represents a fatal form of a type 1 hypersensitivity reaction. Yellow jacket venom activated massive mast cell degranulation and in adrenaline, which produce histamine and leukocytes and cytokines. The release mediators triggered bronchoconstriction and increased vascular permeability and airway edema, which blocked airway airflow and reduced gas exchange in the alveoli. The insufficient ventilation of alveoli compared to perfusion creates a ventilation perfusion mismatch, which results in hypoxemia that manifests as his low SpO2. The body responds to tachypnea to boost oxygen absorption for maintaining proper gas exchange. Secondly, Adrian's bronchial asthma amplifies this response. Asthma presents as a condition with persistent airway inflammation together with heightened airway responsiveness. Allergic reactions trigger severe bronchospasm in asthmatic airway, which leads to increased airway resistance and worse ventilation. The process creates elevated breathing effort, which results in insufficient oxygenation and produces both hypoxemia and rapid breathing. The combination of type 2 diabetes and acute hypoglycemia in Adrian leads to impaired immune and inflammatory regulation. High blood glucose level damages neutrophil function and increases capillary permeability, which results in pulmonary edema. His breathing becomes more restricted because of a condition which decreases the amount of oxygen that can diffuse into the alveoli. Together, the anaphylactic reaction, asthmatic bronchospasm, and diabetic induced inflammatory dysregulation culminate in poor oxygenation, which forces tachypnea to emerge as compensatory mechanism and hypoxemia as a clinical sign. Hence, it is that Adrian's rapid breathing and reduced oxygen saturation are neither separate signs nor independent symptoms, but are actually the consequences of the intersection of multiple acute and chronic disease. It is a fundamental knowledge for early targeted interventions such as oxygen therapy, adrenaline, bronchodilators, and fluid resuscitation of the respiratory system that can be developed very quickly to be the best treatment for the patient. Thank you.
Hello everyone, my name is Siardul. Today I will be addressing question 2, which focuses on the pathophysiological link between Mr. Adrian Shani's clinical deterioration and his underlying conditions. Specifically, I will be discussing how Mr. Adrian's delayed anaphylactic reaction leads to hypotension and oliguria, which are two of his high priority clinical symptoms that, as a result, contribute to the development of multiple organ dysfunction syndrome. Mr. Shani's hypotension is one of the main indicators of anaphylactic shock, which is defined as a severe symptomatic hypersensitivity reaction. His immune system produced a type 1 hypersensitivity reaction after being stung by a yellow jacket several times, which results in the release of a large amount of histamine by the mast cells and basophils. Moreover, during an anaphylactic reaction, the low blood pressure occurs immediately due to widespread vasodilation and increased vascular permeability, mainly by the enormous release of mediators from the mast cells and basophils, which consist of histamines, prostaglandins, and leukotrienes. Furthermore, all these mediators act on alpha-1 adrenergic receptors, which causes the vasodilation and capillary leakage, resulting in the occurrence of distributive shock. This causes the shifting of intravascular fluid into the interstitial space, increases the blood flow, and reduces the amount of blood returning to the heart, which ultimately leads to decrease in circulatory blood volume. In addition, these all lead to a decrease in preload and cardiac output, which in turn lowers the systolic and diastolic blood pressure. Moreover, this sudden drop in the intravascular volume, which is related to hypovolemia, decrease the venous return and eventually lowers the cardiac output, causing hypotension. In addition, bradykinin and prostaglandins are the mediator in vasodilation and exacerbation of vascular leakage, resulting in the worsening blood pressure, leading to impaired tissue perfusion. Moving on to the second most high priority clinical symptom in Mr. Shani, which is oliguria. Oliguria is a pathological response that is directly linked to anaphylactic shock. In critically ill patients like Mr. Shani, oliguria frequently develops because of neurohormonal activation, which involves the sympathetic nervous system, elevated vasopressin, and result in the activation of renin, angiotensin, aldosterone system (RAS). Moreover, all these factors together cause symptomatic vasoconstriction, decrease the amount of renal filtration, and cause the retention of sodium and fluids. Furthermore, these mechanisms cause the blood's vessels to widen and become more porous, which results in a drop in circulatory volume and blood pressure that is 87 over 48 mmHg. This reduces blood flow to the kidneys, impacting their ability to produce urine. In addition, Mr. Shani's glomerular filtration rate is extremely low, whereas his creatinine level is very high. These symptoms indicate that he has acute kidney injury, which is often linked to a severe condition called multiple organ dysfunction syndrome, in which the organs slowly stop working and eventually lead to organ failure. I'll pass on to question 3 to Erica.
Thank you. Mr. Shani's arterial blood gas results indicate metabolic acidosis due to the following indicators of low pH at 7.15, partial pressure of carbon dioxide at 32 millimeters in mercury, partial pressure of oxygen at 50 millimeters in mercury, bicarbonate reduced at 21 millimoles per litre, and high lactate levels at 4.9 millimoles per litre. Metabolic acidosis occurs in later stages of distributive shock relevant to Mr. Shani's recent insect bites, activating type 1 hypersensitivity response resulting in anaphylactic shock. His increased carbon dioxide levels and reduced oxygen levels are a result of inefficient gas exchange at the alveoli level, as the underlying pathophysiology of anaphylaxis is the overreaction of the adaptive arm of his immune system, which recruits immunoglobulin E antibody. From there, eosinophils and mast cells release and degranulate respectively to release chemical mediators such as histamine and cytokines, which activates an excessive immune response in the form of vasodilation and increased vascular permeability, shifting fluid from intravascular to interstitial space, resulting in edema. This additional recruitment of fluid in the alveolar space hinders gas exchange as the distance has increased for oxygen to diffuse across the capillary membrane. Furthermore, this causes a shift to the right on the oxyhemoglobin dissociation curve, uncoupling oxygen's affinity for hemoglobin and in turn impairs tissue perfusion and reduced organ perfusion, resulting in hypoxia and hypoxemia, respectively. Mr. Shani's reduced bicarbonate result of 21 millimoles per litre indicates an acid-base disorder as it correlates to his kidney's compensatory mechanism to release more base to counteract the additional carbon dioxide. However, as his kidneys are experiencing extremely low blood perfusion from hypertension, kidney injury has begun and will affect the time and efficacy one can expect from the kidneys before further damage results. Continuing analysis of his blood results, his lactate returned very high reading of 4.9 millimole per litre, indicating he has entered anaerobic metabolism. This process begins as a response to reduced oxygen supply at a cellular level for efficient energy production. Lactate is a byproduct of metabolized pyruvate, producing only 2 adenosine triphosphate molecules rather than the optimal 38 with adequate oxygen supply. This reduction in oxygen disrupts the cell's ability to produce energy and therefore the body's ability to maintain a homeostatic environment, leading into multi-organ dysfunction syndrome relevant to the case study. Correspondingly, Mr. Shani's urine analysis reads positive for the presence of glucose, protein and blood, which are molecules usually too large to access glomerular filtration. When molecules this large have entered the kidney filtering system, this suggests acute kidney injury, as 2 factors relevant for Mr. Shani are damage to his kidney endothelial cells from chemical mediators released in response to the allergic reaction and severe reduction of blood perfusion due to hypotension. The kidneys are highly sensitive organs and usually the first to respond to a change within the body for the goal to maintain homeostasis. With contributing symptoms from the case study, this can be explained by Mr. Shani's anaphylactic response leading to multi-organ dysfunction syndrome. Thank you.
Given Mr. Adrian Shani's urgent manifestation of prolonged anaphylaxis accompanied by multiple organ dysfunction syndrome and possible anaphylactic shock, 2 pharmaceutical therapies that are deemed necessary in aiding improvement within his condition include adrenaline and salbutamol in nebulizer form. The main potentially fatal symptoms he is displaying are airway blockage, bronchospasm, hypertension, hypoxia, and systemic inflammation. These chosen drugs target these symptoms by their pharmacodynamic characteristics. Salbutamol is a specific beta-2 adrenergic agonist that activates the adenylate cyclase enzyme while increasing cyclic adenosine monophosphate, also known as cAMP, synthesis within cells by linking to beta-2 adrenergic receptors on the smooth muscles of the airways when nebulized. This action improves calcium bonds to the cell barrier and enables instant muscle relaxation, therefore aiding bronchodilation by lowering the calcium content inside cells. With the previous diagnosis of bronchial asthma, Mr. Shani has severe difficulty breathing, including tightening in his chest region, stridor, generalized wheezing, and an SpO2 of 86% on room air. Additionally, he can only express himself in brief words and has a high respiratory rate of 30 breaths per minute, both of which are indicators of acute bronchospasm and airway restriction. Administering salbutamol via nebulizer in Mr. Shani's case is vital given this drug results in bronchodilation, reducing obstruction of the airway, and enhanced airflow by relaxing the bronchial muscles and widening airways for a period of 4 to 6 hours. Delivering salbutamol on a high oxygen flow of approximately 15 liters per minute with a non-rebreather mask is suggested for individuals with an SpO2 around 85% on room air, such as Mr. Shani, as this method delivers medication straight to the respiratory tract and relieves symptoms quickly. Although given Mr. Shani has recorded a high rate of 132 beats per minute, adverse reactions including tachycardia and trembling should be closely watched. In order to reserve the physiological processes that are causing Mr. Shani's decline, adrenaline is the initial the initial course of action for anaphylaxis, as it functions on two distinct and significant classes of receptors in the body. It has a restricted therapeutic spectrum and pharmaceutical impacts on the targeted organs that are mediated via bidirectional cyclic adenosine monosphate. The alpha-1 adrenergic receptors cause vasoconstriction, which increases blood pressure and systemic vascular resistance, addressing Mr. Shani's hypertension of 87/48 millimoles of mercury and inadequate perfusion, including his chilly extremities. During shock, beta-1 receptor stimulation improves the cardiac output by raising the heart rate and contractility of the myocardium. By encouraging bronchodilation and preventing mast cell degranulation, beta-2 receptor stimulation lowers the continuous emission of histamine and other agents of inflammation. Adrenaline is normally injected intramuscularly at 0.5 milligrams into the midsection of the patient's thigh, with a recurrence every 5 to 15 minutes when necessary, depending on the signs and symptoms being preserved. In light of Mr. Shani's disorientation, angioedema, oxygen deprivation, decreased urine production, and high lactate of 4.9 millimoles per liter, adrenaline is necessary for regaining circulation and oxygenation and to halt additional damage to the organs. Essentially, nebulized salbutamol and adrenaline work pharmacologically synergistically to treat acute asthma-related anaphylaxis. While adrenaline restores systematic vasodilation, airway edema, and the production of inflammatory mediators, salbutamol offers rapid-acting bronchodilation. When combined, these are life-saving measures that are essential to enhancing Mr. Shani's medical state. This is now the end of our presentation. Thank you for listening.